Ahí va. Mandando inglés, 1, 2, 3, mandando inglés. ¿Bien? Va. Good morning, ladies and gentlemen. Can you hear me okay? Good morning, ladies and gentlemen. This is the second day of our online conference on mental health and social security put together by the conference, the Inter-American Conference on Social Security. We're having a couple of technical issues, so please hang tight for a couple of minutes. In the meantime, you have on the screen our presenters for the day. Thank you. Hello again. So as not to delay the start of the event any further, I will pass the floor to Dr. Estela Altalef. She's an expert, a subject matter expert, aside from being a president of the American Commission on Senior Citizens from CISS, which is a technical organization that accompanies this international organization in this subject. So I will pass you the floor to start your work as a moderator on today's conference. Well, thank you very much. And thank you very much for providing us with this space to be able to develop such an important subject for senior citizens. And the fact that we can summon so many experts like the ones presenting today is to me a personal satisfaction, of course, because they're friends of mine throughout my professional career. And well, let's start. So from the American Commission on Senior Citizens, CADAM, I think we've found it necessary to talk about subjects that make up mental health for senior citizens. Our presenters are Dr. Ricardo Jakub, Dr. Ricardo Allegri, and Dr. Julieta Odon. I would like to present to you the framework that we've given this from CADAM. And let's start from the rights and wishes of senior citizens, which is something that have been displaced or delayed or neglected even by the social imaginary many times. And I think that it is from here that we need to better frame and develop all our actions. We believe that all people have the right to aging healthily. We need to provide them with opportunities, and, well, of course, senior citizens also have responsibilities to achieve this healthy old age, which is what Social Security needs to be able to exert solidarity in a more balanced and equitable way. For there to be this healthy aging, senior citizens have the right to support and care whenever they need help on their day-to-day life, which is, well, the best traffic light, if you will, of healthy aging. And remember that there's no human right or citizen's right or any health practice that cannot apply to people because of being senior citizens. That's age discrimination. And that's something that really impregnates the social imaginary. And that affects us as people, as professionals, as politicians. And that even seeps into senior citizens when they start feeling that everything happening to them is because of their age. To us, healthy aging means not depending on anybody else for day-to-day activities, for daily life activities. And we consider that diseases are there. Throughout time, you start gathering diagnoses. But it's not the worst thing that can happen to a senior citizens, but rather a situation of depending on others. And here, mental health plays an extremely important role. It is very clear to us that for them to be self-sufficient and to, aging, this quasi-miraculous process we're undergoing for aging not to become a catastrophe for people, for families, for communities. The only strategy to prevent this, of course, is prevention. And I don't know if you can still see my presentation. Because all of a sudden I see my presenters on the screen and I cannot see my PowerPoint presentation. Please wait just for a minute. I just lost my PowerPoint, so bear with me for a second. Doctor, you can minimize your screen. I think that will solve your problem because we can actually see your presentation. Okay, moving on. So again, the strategy is prevention, and each person has the right to having a health system that's adequate to his or her conditions. That is to say, person-centered, as an individual, as a senior citizen, and the system should include very strongly long-term care. So we need to think how to understand the complexity of senior citizens. And all of us working in geriatrics, gerontology, everything pertaining to life and health of senior citizens, we know. And we do have a special strategy, which is the integrating gerontologic assessment. And this is nothing theoretical in sense, but rather something practical that should be present in the daily practice of all those professionals or non-professionals who works with senior citizens to be able to understand them. If today in the clinical history of an institution you cannot see integrating gerontological assessment, it's because it's not senior citizens are not being taken well care of. And that affects society in general. And they need to understand that to be able to approach a senior citizen and being able to take care of them, they need to take into consideration these four components: the medical biological component, the psychic cognitive component, social component, and the major component, which is a result of the stability of lack thereof of the other component, which is a functional impact on on performance on day-to-day life. So we need to ask ourselves, how are we supposed to respond to this complexity in senior citizens? Well, starting from this integrating gerontologic assessment through prevention, through care policies, and through an integrating attention center, or rather integrating attention system, person-centered. And this will be the great change in public policies as it pertains to senior citizens, having them as core. So from this standpoint, we can start talking about mental health of senior citizens. And, of course, thinking about this major component, which is the integrated gerontologic assessment. Except for this work table, we thought about bringing in psychologists for senior citizens, contributions from people, experts in cognitive issues, and this large component, which is care. That's why our participants are Ricardo, Jakub, who will talk about psychology, Ricardo Verte talking about cognitive matters, and Dr. Julieta Odone. She will talk about the impact of care. So if it's okay with you, I will pass the floor to Dr. Ricardo Jakub. Okay, so I just stopped sharing my screen. Can you hear me? Presently, I cannot see your screen, doctor. Hello, can anybody hear me? Can you still hear me? Yes. Yes, we can hear you, doctor. I think the problem is that you minimize your presentation. Chances are that's why we cannot see it anymore. But you were able to see my presentation? Yes. Not right now, but we were able to see it. Oh, okay. So I would like to go back to general screen so I could pass the floor to Dr. Ricardo Yacu. Okay, so we have all our participants on the screen. So if you want, we will pass the floor to him right now. Okay, so let me introduce him, Dr. Ricardo Yacu, a BA and doctor in psychology from the University of Buenos Aires, Argentina, lead teacher of psychology senior citizens from UVA, and member of the Institutos Psicosociales de Servicios Sociales para Jubilados, guest speaker in different colleges in America and Europe, and a published author. Ricardo, the floor is yours. As it pertains to the emotional resources of senior citizens. Thank you very much, Estela. I'm delighted to be able to be working with this team. So my choice for today's talk has to do with the impact COVID has on senior citizens, which in one way or the other made us think. What happened with this very particular situation where senior citizens were placed as the people most at risk? However, research didn't show some paradoxical aspects on this subject. That's why I chose this picture. You see some senior citizens, and behind them, soccer players like Messi. And here, resources could be analyzed differently based on the data we'll be working on today. So the reality is that senior citizen and the pandemic, old age has become this trending topic this day and age. Why? Because of the concrete risk senior citizens are under. And because, well, some suppositions thought of senior citizens as a group were lacking a lot of things in fear and at most risk, not only physical, but only psychological, but also psychological. Nevertheless, what the research shows is that in as much as people increase their age, there are less symptoms or psychological symptoms like anxiety, depression, and loss of sense of life. So this research was done in Argentina. And this indicates in each of these reports that the same data. Another research done in Argentina shows that senior citizens over 68 are the ones who show less anxiety, depression, and sense of loss of sense for life. So if we check data from the United States with and large journals, is that the same trends made evident? From the UVA, we do research in several different scenarios, that is to say, in May and September, situations that had nothing to do one with the other. Because, well, in one, we were under quarantine, the other, we weren't only in quarantine, but at the peak of the virus and with large amounts of deaths. Nevertheless, the relationship of senior citizens with pathology, with fear and anxiety was relatively modest. I mean, it's not that they were not afraid, but they seemed to find coping mechanism before these fears. And, well, this draw the attention of several people. In my case, we've been doing research and following international research. We wanted to pinpoint one of this explanation based on what we're working on as, or we call emotions in old age. So the large majority of this research haven't been around for over 2 decades. So research show a high degree of affection, well-being, and emotional stability well until 70 and 80s. And there's something called the well-being paradox by Morsecki and Kollars, and which says that beyond all the difficulties brought about by biological aging, I mean, there are some psychological changes in old age too. And the society, like Estella just mentioned, with high levels of discrimination against senior citizens, however, well-being levels are high. And as a matter of fact, in following research, which are very strong right now worldwide, what they show is that there are two ages which seem to be the happiest. One is 20, people in their 20s, and another one, people in their 70s. With current research that says that this age going over 70, and they're showing that during the 80s, people are still very happy. This seems a paradox. And what we will try briefly to describe is why do we understand these things happening and the large amount of research that has been done on this subject. You all know that emotions are communication links which precede us in some way, shape, or form. They appear with our biology, and they organize primarily human thought and behavior. That's why all sorts of memory, all sorts of behavior should always be linked to an emotional system and to more complex forms that we will take a look in just a moment. The limbic system plays a very prominent role in emotions. You know that these emotions will interact, like I just mentioned, with cognitive processes like perception, memory, thought, and action. And all this development coming from Freud and previous researchers like Jacob already talked about this relationship between thought, memory, and emotions. And we also know that prefrontal lobes and frontal lobes can assimilate emotions through something that we'll be working on a lot, which is modulation and planning. That is to say, there's something that has to do with all the executive thoughts that will shape changes at the emotion level. And I think that the same thing that happened to doctors is happening to me right now. I can no longer see my presentation. Okay, so you know that there are some emotions which are stable and we share with superior anthropoids, which are anger, sadness, happiness, that have some neurophysiological properties, phenomenological, and physiognomic and motivational properties. And, well, these are handled by common biological basis. However, there are also some qualitative nuclei like euphoria, joy, anger, that will be changing throughout time. But what we find, and what we have found, is that there's something that will start modifying emotion, and that has to do with cognitive assessment. That is to say, in what way we provide sense to what happens to us, how is it that we evaluate situations, and what type of value we provide emotion as well as motivation, which is one of the core elements to be able to think, and the way we associate emotions with very particular motivations. That's why the question is if emotions change with age and in what way this happens. In principle, what we found is that the relevance and understanding of emotions will change throughout life, related to more urgent, more important situations, depending on the life stage, depending where in your life you're at. And we'll have a particular incidence in which emotions will be most important. So which emotions will be more important to us in our life, and how we're going to relate that to certain emotions. But there's something else that has to do with how we understand emotions and what priority we give emotions. So, in principle, we could say that modulation, as a job of frontal prefrontal cortex, says that it improves the modulation of expressive behavior, acquiring something we were surprised with during our research. When faced with many research made with young people, the sensation was haste, anguish before the situation, not being able to deal with this anxiety of not being able to do things. And older people say that you're supposed to have tolerance. And the same answers were provided in Chile and other countries in Latin America. And this gave way to research that supported a very strong empirical evidence. And what this research shows is the difference between primary and secondary control. Primary control associated to those things we want to do immediately, right away. In secondary control, those that we cannot do right away. And which cognitive effort is trying to find new resolution ways to keep motivation. That is, say, being able to delegate what I cannot do it, being able to postpone it, finding possible variables. Because the core interest of human being is keeping himself or herself motivated. But what we also have here is an increase in association of differentiated emotions to images and thoughts. Just an example of this. There was work in Stanford, a college in the United States. In the beeper test, they call it. And during one day, people from different ages were given one sort of beeper where emotions were differentiated. So throughout the day, what they saw is that senior citizens were the ones who were able to identify differentiated emotions in a better fashion. And well, when we talk about differentiated emotions, what we see, what's underlying to this are images and thoughts that happen through time. And this allows people to be able to distinguish different emotions before day-to-day events. Labouvieviev, a Swiss psychologist, says that what increases with middle age is affective cognitive complexity. And, well, what she says is that positive affections maximized, thus minimizing the negative ones. This subject is being worked tremendously by a lot of pieces of research, current pieces of research. But there's also something, and then after that I'm going back to this, but something that opens up here is affective complexity. So as you grow older, there's a larger tolerance to affective tolerance. Being able to find that life presents to us some contradictory and contradictory aspects. This comes as a result of certain mourning where people learn to share with positive and negative aspects at the same time. And with a flexible affective regulation, this is very common. And, well, this is just an example of terminology, finding senior citizens crying before a story and something day-to-day, but that they can immediately start laughing and enjoying life again. So, Laura Cartensen from University of Stanford, great researcher, says that this indicates pathotism, which is the possibility of sharing differentiated emotions and learning to live with differentiated emotions. And what this whole line of Laura Carter from Stanford says is that this allows for senior citizens to be able to have more depressive symptoms, but not more depressive illnesses. This emotional regulation before affective complexity makes the levels of disease, depressive disease, become low. And you also know that all psychopathology in senior citizens, in general terms, tends to decrease before other ages. So we still have the same notion. We can have some encounter feelings and being okay with this. That is, say, sharing positive and negative emotions, and that's what we found in the research, that with it, both quantitative and qualitative regarding COVID, where people tell you that they were anxious, but at the same time they have coping mechanisms that were able to reduce fear of death, or they could be experiencing very important degrees of anxiety, but not letting themselves be afraid. So anxiety and fear sometimes go hand in hand, but these people had complementary mechanisms that could make one raise, but the other decrease. The aspect more related to fear or even sadness. So in general terms, what we can find, and that there are a lot of research on this, very interesting research on this and how this come about, is that senior citizens prefer images and stimuli which are not so positive or not such high activation. So when we find, or when we ask teenagers, younger people, what we see is very positive, very negative levels of affection. It's like they go from 10 to 0 and nothing in the middle, no buffers. So teenagers go from being very joyful to be very bored or depressed, while senior citizens, we see that these activation points are not so high. But they work in a median between 7 and 8, which makes well-being be more continuous. So there are many ways to explain this. Cartenson's and Charles and Blanchard-Schiff's way of thought insists a lot in central regulation, that is, trying to restructure daily environment. To what purpose? To try and not find negative situations. If I know that I'm going to meet someone who I am no longer interested in, you probably reduce that contact, that person. If I know that there are situations beyond my control, I'll probably tend to avoid them. So we're likely to find more avoiding mechanisms. And what we see here is that these people are highly functional. So in this point, they tend to avoid day-to-day stressors and negative encounters. So you will know of senior citizens saying, well, I don't see that people because that person depresses me. And that behavior is called avoidance, or avoiding behavior. So what people learned, and I include myself as a middle-aged person, is the emotional effects I just mentioned. Some events, what we like, what we don't like. And when we were younger, we tried to try many things. Or put your fingers inside the electric socket to see whether you're going to get electrocuted or not. But in this point, you adapt emotional regulation strategies more pertaining to the environment we're at, trying to regulate the environment we'll be in with the people we will be with, trying for these things not to overpass a certain measure of what's controllable for us. And what Scheib and Blanchard feel say is that there's less effort in this regulation process. And this would suggest that that's an effect, clearly, that comes from experience. We also found something that we can see in international experiences as it pertains to quarantine and COVID. See that senior citizens had less conflicts than younger people. They seem to be less anger in interpersonal situation, and they generate more efficient strategies, one of which is forgiveness. So in this research, and I will later talk to you about other research under this same subject, but we found that senior citizens tended to forgive easier than other age groups. And again, well, trying to avoid interpersonal confrontation that could be harmful for them. some more pieces of information. There are changes in emotional regulation, heart reactivity to emotional stimuli decreases. Same goes for negative emotions. Search for positive emotions increases, and the perceived emotional control increases, providing more stability and emotional maturity. So we could say that this, which Lawton pointed out prior to the other authors in one way or the other, something we could call emotional maturity, could have to do with this type of changes in regulation, in self-regulation, in emotional regulation. Obviously, this has limits. And in reality, we could cite some examples before COVID. I mean, when goals are explicit, that is not only taking care of well-being, but, being exact before a certain work or, trying to finish a task, well, that effect is eliminated. So, and when there's perception of threat, there was a small increase before the amount of deaths that we had in September, where threat was a little bit more direct, and that there were less mechanisms to try and avoid or even regulate these emotions. And, well, when this becomes uncontrollable, when people has very few mechanisms. I would like to share with you an example of something that happened in the United States, where senior citizens and younger people were put in a threat situation, X, danger situation, and what they saw was that the emotional reaction was common in the youth and senior citizens, but throughout time what they saw was that senior citizens were able to apply emotional regulation mechanisms that made the situation they underwent to be less stressful as opposed to youth. One of the strongest theories regarding this is, again, Lawton theory and Laura Cartensen. And this is the theory of social-emotional selectivity. And what they have to say about this is that when you know that you don't have that much time to lie, you reassess motivations. And what you basically do is intensify current gratifying emotional experiences. Pretty much privileging that will give us gratification and trying to get that more often. In this way, we can say that we see our prioritization on emotional gratification. That makes many things that we've been saying true. Things like looking for more positive information and less negative information. I'm sorry, Ricardo, you only have 2 minutes left. Yeah, but we started a little bit late. That's why I think I'm still in time. Okay, so this positive effect, this type of working this type of research, and what people are seeing is that this neuron activity before anticipation, exposure, and codification can be made evident in functional images through different types of practices. Davidson, a famous researcher that studied llamas and how they handle their brain. I mean, this is our smaller research. This is small research back from 2004. And more concretely, what they say is that there's a different pattern of cerebral activation, and the prefrontal cortex, the executive control, is more used. So that's what's being working more strongly, because in as much as the executive control works better, all these mechanisms of emotional regulation can work better to limit the activity of amygdalas. And for those of you who don't know it, the amygdala is related to the most destructive emotions. So the less relation of emotion, the more activity in the amygdala. Gabriel, in the same line, we observed comparison, younger people and older people. The comparison is very simple. These two groups are given 2 images, one of an ice cream and the other one is a dead animal. And while youth come and go from one image to other, and they up with that animal. Senior citizens went directly to the ice cream. So Gabriel said that neurologically speaking, senior citizens are looking more for positive effects. You know that this is not a lesser subject. We're not only talking about well-being, but we're also talking about health. There's research that shows that all emotions have an effect in the nervous system and the immune system, and in as much as, and emotions cannot find regulation mechanisms, this could lead to coronary disease, or when there's a very important inhibition of emotions, that will lead to cancer, and many, many other pieces of research we can talk about. For instance, the sensation of feeling alone, abandoned, in solitude, and, well, it has relation to Alzheimer's. So this theme is being worked a lot in the latest piece of research. And then the art of life. This might seem very poetic, but there was a German researcher who proposed this, and we can say that all this regulation is not that just happens because of the fact of living, but it does require adaptations to the environment, which are always conflictive, sometimes critical, and they require new encounters, social networks of support, like Harvard's research, this longitudinal research over 80 years of satisfaction and acceptance. But in one way or the other, this regulation that many relate to wisdom that's been discussed since the Old Testament, appears as some sort of maximum ideal of vital development, where emotion regulation is a means to get a better quality of life. Because of a prior commitment, I won't be able to accompany you any farther. So I'll leave you with this very beautiful image from a Polish author. So thank you very much for listening to my presentation. So instead of saying thank you, Ricardo, from your very positive vision of aging, I thought of two words that could be adapted to what you said, and you repeated that quite a few times. You talked about flexibility and adaptation. I think that would serve purposes, the purpose of youth and senior citizens to further adapt and live a better life. In case you have any questions for you, we will forward them to you. Thank you. Goodbye. Thank you. Okay, so after this very positive note, let's continue with Dr. Ricardo Alegre. He will talk about cognitive deterioration, the importance of national programs. He's a neurologist and psychiatrist, chief of neuropsychology and neuropsychiatry of the Freni Institute in Argentina, professor of neurology in the School of Medicine de Buenos Aires, Universidad de Buenos Aires, president of the Research Council, the government of the city of Buenos Aires, and member of the World Council on Dementia. Ricardo, the floor is yours. Perfect. Can you see my presentation? No. First, I would like to thank Estela for putting together this working table. It is great being with her, with Julieta, with Ricardo. It is my pleasure. Because this broadens the panorama a lot and everything pertaining to aging. And in my case, I will talk about cognitive deterioration and why the need for programs, that have to do with health. Ricardo, I'm sorry, I cannot see your presentation at this point in time. Can you please confirm that you can see Ricardo's presentation? I can see you, but I cannot see your presentation. I'm sorry. Can you see it there? Yeah, we can see you. We cannot see your PowerPoint presentation. Doctor, you've been given instructions on how to share your screen. Thank you. Make sure to follow those instructions. Can you see it there? Yes. Perfect, doctor. Thank you. Very well. Thank you for helping me. Okay, so I will talk about cognitive deterioration. And, well, why the importance of having national health programs and the plans geared towards cognitive deterioration. So let's take a look at some epidemiological data. You can see my presentation, right? Okay, so some epidemiologic data. Second, something related to the social health costs. Then we will talk about prevention, programs, plans, and then conclusions. So why? Everything pertaining to cognitive deterioration is important. If we take into consideration that life expectancy has been increasing and will keep increasing years to come, that between 1840 and 2040, human beings will have duplicated life expectancy. That is to say, the growth of life expectancy is huge. And to the right, what we can see is the prevalence of cognitive deterioration. And, as you can plainly see in that part of the slide, prevalence increases exponentially with age. And as age increases, we have ages, diseases, and the more life expectancy, the more amount and the more frequency of these diseases. And this is ruling axis. Why? Since some time ago, and especially now during these times of pandemics, Plum talked about how cognitive deterioration was a coming epidemic, an epidemic that we need to be aware of and see how we could prevent it, how we could handle it, manage it, and how we could accompany it. Something else that's important is what we see here in the top left corner of the slide. Between the year 2010 and 2050, we can see the increase people with dementia. But also in that same graph, we can see how in countries with mid and low incomes, that increase will be much higher as opposed to high-income countries. And to the right, I'm using this chart that talks about the prevalence of dementia in people over 60 years of age on a regional basis. And the largest prevalence is in Latin America. This is a report from Alzheimer's Disease International. And here we can clearly see how Latin America has more problems as opposed to the rest of the world. In these next two slides, I will talk to you about some work we did a couple of years ago. You might be acquainted with it. We have the Matanza Riachuelo Basin, south of Buenos Aires. And this is within a system called Acumar, the Acumar system. And we had the opportunity some years ago conducting an epidemiological research of cognitive deterioration in this region, the Matanza Riachuelos Basin, which is an area of high social vulnerability. And well, back then we did a door-to-door research, the sample population, September 2012, over 2,000 people, 2,400 people, and we found an 8% of people with dementia and 18% of people with cognitive deterioration. But what's most important and interesting about this piece of research is this part. And what you can see here is that cognitive deterioration in people under 70 years, when you contrast that against the bottom part of the slide that brings together the rest of Latin America and some European countries, when you see prevalence is way higher in this region, which, as I mentioned, is a high vulnerability area. Why is this? Why is this related to? This has to do with the poor control of risk factors that will act after cognitive deterioration. So the analysis that we made then is that in people under 70, people between 60 and 70, the frequency was higher than in Europe. So when you went over 70, the frequency remained the same. And this is due to risk factors started acting and made in younger people having more cognitive deterioration and thus more dementia. What we saw in the Matanza Riachuelo Basin in many international presentations, Ricardo Nitrini in Brazil, in the same type of study in favelas in Brazil, found exactly the same. And this is one of the cornerstones for one to start working on prevention, because the main problem in these populations, the main problem is lack of prevention. And that makes deterioration and dementia to have an earlier onset, and for this to be more serious afterwards. Now, which are the social health costs? It's extremely important for us to know. Back in the year 2010, Alzheimer's Disease International showed which are the health costs through a work of the Karolinska Institute in Stockholm, Sweden, and shows an increase between 2005 and 2010, and how much these costs will keep increasing in the years to come. But what's even more interesting, when you compare this against companies like Walmart or ExxonMobil, the oil company, the cost, the expenditure in dementia is larger than the expenditure of this company separately. And when you compare this against economies in other countries, we can see that dementia, the expenditure, the costs associated to this disease is larger than the economy of Indonesia, Belgium, and different countries. And, well, this is for you to have some sort of framework of what we're talking about and why this was called the coming epidemic. An epidemic we need to act upon. We made an epidemiologic study, a research around the year 2000, in which we studied the economic impact of dementia And, well, we evaluated the costs. For the case of our country, we divided this into direct and indirect costs. In terms of community, it was around $5,000 in indirect and $3,100 in direct costs. When we studied institutionalized subjects, indirect costs versus direct costs, what the family member or caretaker invests in hours, and nobody pays for that, but that person is paying for it with the time. So in institutionalized subjects, you can see how direct costs increase tremendously and indirect costs go down. But indirect costs are very important, and this led to another piece of research that we published back in 2010. We were thinking about the costs of Alzheimer's disease in countries like ours. And the question was, if this burden will be taken by Social Security or by the families, because what we can see in the right, those close to $5,000 is the cost, the economic cost of the time that family member, and well, what you don't pay as opposed to the patients. Then we published another article in 2011 where we separated costs based on the types of dementia. And some of the variables that showed up as the high cost of psychiatric medications. For example, when the disease in patients evolve. And now, why prevention? And if I had to choose something, I think that what we have to do in the years to come is this. It's working on prevention, really. All of us know that the Alzheimer's disease, which is the paradigm of dementia, was described as the de facto dementia. We can have dementia because of other reasons. But as we can see here in the chart, on the left, we have cognitive function and age. On the other axis, we have a cognitive limit and a functional limit. So aging is represented here in the green with normal decline with aging, but Alzheimer's disease had the dementia stage, mild, moderate, and severe, as described by Alzheimer's, a stage of mild cognitive deterioration, and a pre-symptomatic stage that might last for 20 years. That is to say, when we diagnose the disease, 20 years prior, biology and neuropathology was working in the brain, moving steadily. And, well, it just appeared when we did the diagnosis. And what we know now is that we have this dementia stage, pre-symptomatic stage, and mild cognitive deterioration stage. Here we see the timeline of an individual with Alzheimer's disease. So we have the dementia stage, mild cognitive deterioration, and pre-symptomatic. And we see the physiopathological factors from predisposition, genetic predisposition, amyloid deposition, neurofibrillar factors, neurotropic factors, inflammatory factors, and variation of neurotransmitters that lead to the onset of the disease. You have Augusta, the classic patient of Alois Alzheimer's. And we now know that interventions in Alzheimer's disease, what we have nowadays from treatment standpoint are symptomatic treatment. They only act upon symptoms. The great challenge for the years to come is having these medications which are disease modifiers. But we now know that there are 3 levels of prevention against Alzheimer's disease. One, which is tertiary prevention. That is to say, when the symptomatological clinic disease is there. We can accompany the patient for the patient to have a better quality of life. But we also have secondary prevention. And that's when you have biological factors, but you don't have symptomatology. And we have primary prevention before the onset of neuropathology. And this is extremely, extremely important because prevention is now regarded. Prevention because of the factors we will see in just a minute, factors that you need to control. And prevention, I think that is the major challenge with many medication trials that are being tested as it pertains to Alzheimer's disease. So the prevention of these risk factors is extremely important. And Alzheimer's Disease International produced this report in 2014, how to work on the reduction of risk factors. In 2017, this article was published by Lancet Commission. I recommend it wholeheartedly. Actually, I will recommend the latest update this year, but this article, and I think that this article jumped leap and bounds. And it says that prevention of dementia is not only acting upon senior citizens, but rather throughout a person's life. And for that piece of research, 65% of factors are not modifiable. But what's even more important is that 35% of factors are modifiable. Starting by lack of education, early ages of life, middle age, loss of hearing, hypertension, obesity, later ages, smoking, depression, physical inactivity, social isolation, and diabetes. So this prevention or risk reduction last year, the Global Council on Brain Health, we participated in that. A whole report was produced with recommendations and with the concept, what's good for the heart is good for the brain. All these that cardiologists have been recommending for many years now as an axis for everything pertaining to prevention of myocardial ischemia, heart attacks. All these factors are also good for the brain. Physical exercise, not smoking, managing blood sugar levels, hypertension, cholesterol, diabetes, getting a good amount of sleep, and eating a healthy diet. So we published this last year under the World Council of Healthy Brain in the United States. So together with this, WHO came out with the risk reduction of cognitive decline and dementia. These are WHO guidelines. And, the comment is on the same factors. Miyake Vipalto, with her work as it pertains to prevention, working on all these factors, which are modifiable. And again, this is interesting because the latest publication in the Lancet Commission from Livingston, these risk factors were reassessed. And here you can see how 60%, it used to be 65%, but now 60% are non-modifiable, but 40% now are modifiable, like level of education, loss of hearing, brain injury, hypertension, excess alcohol, obesity, and smoking, depression, social isolation, physical inactivity, pollution, air pollution, diabetes. All these are risk factors for dementia. But this is worldwide. What happens if we focus in Latin America? 56% of factors in Latin America are modifiable. Why? because probably us control even less hypertension, obesity, all vascular factors have very scarce control, very scarce prevention in our countries in Latin America. And that makes prevention work. If you carry them out in Latin America, they should have more impact in Latin America as opposed to countries like Switzerland. Last year, we had this meeting. And this is part of the Worldwide Fingers Project, 13 countries in Latin America, working on the Miativ Keltos project, having to do with control of risk factors, cognitive stimuli, physical stimuli, and following a correct diet, an adequate diet. This publication just came out in Alzheimer's and Dementia. And, well, you can see here Latin America and the importance of Latin America within the whole project. In closing, what is that? What do I think, and why? When Estela told me about the theme of this working table, I thought about talking national projects. So the WHO a while ago proposed governments, because again the problem with cognitive deterioration is not a problem of the doctor's office or the family. Suffered by the family. Certainly, and healthcare professionals try to solve this problem, but this is rather a problem of public health. This is a problem for governments, and this should, of course, be taken into consideration. The member states of the WHO having programs, plans, or some systematic actions on dementia are the ones we see here. I'm sorry, we lost audio. Hello, doctor. Good afternoon, doctor. We cannot hear you. I don't know if you could stop for just a second. I'm sorry, doctor. We stopped hearing you just like a minute ago. Yeah, just a minute ago. That's when the connection was, or seemed to have been interrupted. Well, I could probably restart from here. I'm sorry, just backtracking a little bit. Like I told you, the great importance, national plans. The WHO has developed this whole strategic plan for governments to become aware of this. And in the green, we have those countries where there's actions or plans or programs. And this is extremely important. We are extremely concerned about this. In the year 2011, we made a centralized registry of cognitive pathologies to be able to do an epidemiological follow-up, some sort of surveillance system, and having a sample of what was happening in our region as it pertains to cognitive pathologies. So again, just in closing, when you think about carrying a plan or national action, the first place we need to think about the core problems. Problems on people with the disease, problems with the caretaker, and problems with the family. The objectives. Of course, in the disease, the objective will be for working on a cure for the disease. We shouldn't forget that the core of a problem is the patient, not disease per se. So we need to think on how to work to help the patient and the family. So you have this triad: disease, patient, and family is an objective for our development. Again, the objective will be cure for the disease, care, and respect. These will be the three main objectives. Now, the actions that we need to carry out include sanitary actions. They include social actions, social assistance actions, and they have to include investigation actions. Research in our countries. Why? Because each of our countries has its own singularities, and we need to work on these singularities in our own countries and not trying just to copy models directly, but rather trying to work on models adapted to the culture, the mindsets, and, well, the realities of our countries. And, well, I think that at least the Ministry of Health should be involved, Social Development Ministry should be involved, and Science and Technology Ministry should be involved. This would be the general plan that we have in terms of the development of programs. And if you asked me some sort of conclusions to this, first, I would say that Alzheimer's disease is a silent epidemic. 55% of factors are preventable. So the way to tackle this should be disease and patient and family, and it should be a priority in public health. And if I had to choose just one action, and the cheapest, I think it's working on prevention. So thank you very much again. Well, this is the center and the people, the group of experts working with me. Thank you very much, Estela. Thank you very much for the invitation for sharing this table today with us. Thank you very much, Doctor. Thank you for your important contributions. Dr. Estela, can you hear us? So, Doctor, thank you very much. Very valuable presentation that leaves us with a lot of food for thought. And Study Cadam is a very important commission devoted to senior citizens in the CISS. And we have other programs next year to provide follow-up to the importance of senior citizens. Of course, this problem is very big. We've also talked about how the pandemic made evident all these long-term care problems. And some problems have been accumulating. And unfortunately, we haven't paid due attention in our region. So we should place emphasis to all this. That's extremely important. And again, thank you very much for your participation. And next year, we might contact you all again with the purpose of documenting these presentations, with the purpose of widespreading all this knowledge. I don't know if a doctor is there. Was she able to get a connection? Doctor, can you unmute your microphone, please? I can't hear you, Doctor. While the doctor is able to get back online, I'll pass the floor to our next speaker. She's a friend of the Inter-American Conference Social Security. She wrote a very pertinent text for the Commission talking about long-term care. And she explained the problem in the region, something that we didn't have prior to her research. And you can have access to this piece of research in our web page. Dr. Julieta O'Donnell, the BA in Sociology by the Buenos Aires College, Magister in Gerontology by the Universidad Nacional de Córdoba, Doctor PhD Anthropology by the Buenos Aires College, lead researcher on the Argentinian Nation Research Council. So I will now pass the floor to Doctor's presentation. So thank you very much, Doctor, for being here and for your presentation. We will listen to you very carefully.
Thank you very much. I hope you will be able to see the material I'm presenting and you will be able to listen to me. Yes. Okay, then just to give you a little bit of context, I like to present this figure, this image that is related to the populations getting older. Two important factors, which is life expectancy, is it was mentioned by our prior speaker, and on the other hand, the reduction of births. So this triangular image upside down shows a trend in many societies in the world. This is talking about the Chinese society, talking about a one only son. But that doesn't mean that families in the past would have a perfect triangle where there was a little, lots of descendants, and every time more and more, due to the demographic changes given all over the world, we find that nowadays families have lots of ascendants but very little descendants. So it's been pretty difficult for the population to strive against this situation. So let's see if I am able to care management implies that we would need to organize resources, effective and symbolic materials, activities and services that would be feasible, feeding and health, personal hygiene, and processing of social processes. Generally, all societies care, according to Masavi, is like a diamond where you will have to organize the family, the market, and OGs, NGOs, and that care. Given the services of these institutions, is going to have an effect on the people, on their care and the caregivers. I'm going to base my presentation in three research pieces. One, quantitative, which is the PISAC study performed by the Ministry of Science and Technology in all the universities of Argentina, which included 8,200 homes and 28,000 people. What I saw here, I analyzed the senior citizens population. So we see that 90% of elderly people older than 65 years old, they do not need help to run their errands. But that 10% that needs help is formed by mainly women. 2/3 parts women and 1/3 part men. And in general, and at the same time, what the previous position was telling us, as they get older, then we would need more help and cooperation in our everyday life. And if we consider the educational background, so if we see that those that have elementary school, they would need in their elderly ages would need more help, more than those that had access to university education. And this is linked to the socioeconomical level. That is to say, it has to do with the care we've had, not only in the elderly ages, but all along the life cycle. It has to do with prevention and the context where we have developed our life. Thus, 11% of people of low income class, with respect of those that high income class, they would need care. If I go back to the scheme of the care diamond and I see the people that take care for their elderly people or senior citizens, we'll see that we have different regions in Argentina. And what I want to pinpoint is that mostly it is done by a person in the household, that is to say, a family member or a friend of a family that does not always is not always there. Sometimes somebody that has been hired, when this person that has been hired specifically, or a domestic worker. So what we're saying is that also in the family, if we're looking or they're looking up in the market, those that finance this expense, that is to say, only between 1% and 5% of those that need care according to the region, and in some regions there's a lack of care, they are financed by a home care program that is related to the state or public state organizations. That is to say that the caregiving generally it's because we have the body in for the care for somebody, or we finance it is fundamentally on for the family that take care for this senior citizen. I would like to say that within this research, and this is why I wanted to show how the caregiving has been changing in accordance to the population getting older. We see that elderly people taking care of other elderly people is the 8% of the sample. And these caregivers, the 24%, 34% are men and 65% are women. That is to say that if it is true that most of the care is given by women, we have a third part of people, men, that take care for their family members, particularly and many times their spouses. And in this group, 9% are people that are around 80 years of age and more. That is to say that the people that are older than 80 years, in this case it's 35,000 people, they are taking care of other senior citizens that need their help. I'm going to refer myself to other two pieces of research that we used, qualitative techniques, which are a research performed for the Buenos Aires University or from the Buenos Aires University to talk about or analyze the public and social policies related to senior citizens that had a quantitative and a qualitative part as well, and another piece of research that was performed specifically with caregivers of highly sick people and highly dependent people. We talked about life stories of the different parts and direct observation. In relation to the care, we wanted to know the quality of the relationship between the caregiver and the cared, and the kind of support they receive, the changes in the quality life of the caregiver, like depression, stress, and illness, and family conflicts related to tensions, aggressions, violence, abandonment, negligence, and the strategies that were implemented to care for the elderly elderly people and the degree of satisfaction with the implemented strategy. The two qualitative samples were for 15 caregivers belonging to the family, and in the other case they were 31. Out of those were people that were older than 80 years. And particularly those that I selected, those were the ones I selected to talk about this situation. In both researches, we obtained very similar results in relation to the work of a caregiver. In this sense, the informal caregivers undergo stressed situation and they remain in the task given the ethical and moral values. And if there is something that sustains the care situation and these family members, is that moral relationship. Is it here? I cannot stop doing this because he gave me life, for example, in the case of parents and or in the case of siblings. No, these values are sustained by a psychological mandate, and it's about a pact that is sealed by filial solidarity. I cannot stop doing this under no circumstance, they say. And this is the case of two people, actually, that are much older than 80 years. And Celia says, and what happens is that I wanted the best for my little sis. And then my sadness is this, what happens with my sister. I'm really sorry. I gave her everything from myself. Actually, in these two cases, such as in the case of Chana, that takes care for her sister with Alzheimer, both of them older than 80 years, say, well, I was like perceiving this, but we had kind of like an obligation for the rest of our lives. We were orphaned, we had to fight together in life, so I cannot leave my sister, no way. So sometimes this pact is a little bit different because when the caregiver is a spouse may get tired in the relationship, you know. This obligation's kind of different when this covenant is a blood covenant or pact or agreement rather than a contract which actually would be over. So sometimes in the relationship of care, old stories come because we say, well, I have to do this for him because he left me alone when I needed him because he went to do something else. So this is the case of Hilda, which is also a very elderly person, and his husband suffers from Alzheimer, and in sometime in their life they were separated, and now she says, I wish I would continue separated because now life is very harsh for me. Or in the case of Ophelia that says, well, I do all I can in order for him to be more comfortable. But indeed, my life changed a lot. I have no time for myself. Among the feelings that give support to the caregiving function, there is one that is pretty similar to those that mothers have about their babies. What we have, the dream of stepmother, which we call it like the topic of responsibility of a person with serious care problems, is that the caregiver feels the need, the permanent need to be aware of this care. That's the responsibility that the caregiver has before vulnerability. They can never cut that situation every day, every night. The minimum movement implies, the caregiver to be aware what is happening to the person he's taking care for. But in this dual situation, there might be some reciprocal victimization relationships that generate conflict with the people that are sick as well as with the people that are taking care of these sick people. In a case, for example, is a case of a daughter that is undergoing economical hard situations, and her mother, let's say that is disabled, and she does everything she can to have her pretty well cared. She organizes a family reunion to make her happy, and her mother says, I would like to be dead. And this is where we have, for example, like in this case, situations of, and then I get mad at this because then I shout and I start having this situation of going and taking and like it's like victimization. I do a great effort and she doesn't acknowledges it. So there's like a game between the caregiver and the person cared where this is difficult to stop. Chana and Ophelia, which were the cases I was talking about, they tell us that sometimes they get mad and sometimes it's pretty difficult for them and they're pretty sad and they have depressions, situations of depression, and they even have a need of some kind of specific treatment to face the situations that generate this kind of relationship. Not only about dependence, but a lack of recognition and a certain situation, if you wish, of love and violence, love and hate, given in this kind of situations and relationships, especially when the cared person has cognitive problems or when she's pretty depressed. The caregiver receives very little or no thankfulness at all, and this generates a lack of tranquility situation that leads them to become sick. That is to say that the caregiver begins to get sick. First, because he's tired and the anguish, and then psychologically and physically, because you have to the body charges for all that effort. So this generates to think of how we built the cost of the giving care for caregiving families or for caregivers in general, because we're working with caregiving families, but this can also happen to a hired person that remains 24 hours in a situation of giving care for a person that demands a lot. So for Montgomery, this subjective state of the cost of care is associated to the degree of the discomfort originated due to this cost and objective consequences such as lack of free time, the charge of, it's not only giving care, but it also has a subjective charge that is related to a set of feelings or negative perceptions on the part of the caregiver about his or her function. That is to say, it's the degree of discomfort that is originated by the continuous caregiving. So because what actually happens is that in general, when a person which is dependent and he or she has a caregiver, sometimes it's not a family member who cares or takes care for this person. Sometimes the one that cares is a caregiver. And even though there might be another person, if the relationship of this agreement and it doesn't allow to give some assistance to the caregiver. There's nobody that is going to care better than I do for him. So between the charge of the giving care, what this refers to is the lack of independence, the lack of free time, the lack of future personal time. Mainly if they are elderly people, that are taking care of other senior citizens. So the feeling is that I am, getting without no future, because I'm not going to have any future at all. I'm completely included in this relationship. So the loss of physical and psychiatric health, and the great economical expenses that risk or endanger the future of the caregivers. And as we said, they are elderly people too. But even in people or families that are young, which is the case of the other research, where we work with children, brothers, and we saw also how the economical cost have an influence in the resolution of the everyday life of the caregivers. Actually, this is the case of Celia, but also from another person, that they had to sell the apartment where they live in order to pay the cost of the disease. In the case of a mother and an aunt, and in the other case of a sister. This is a pretty interesting case. Both cases are interesting because this lady, in order to help her sister, she had to sell the apartment where she lives in. And immediately after she sold the apartment, she had another situation before the public policy system. So she had to become poor in order to have access to the public policy. So in this case, she was able to have a subside to pay the rent of the previously house she owned. That's a paradox, because in general, social programs, give a certain limitation to the support or help in relation of the care of people, or the caregiver and the people, that care for this sick person. So if I'm not within that baseline of public policy, I will find myself into a paradox, like in the case of Celia, or the other case that I was talking to you about. The other case was even more difficult, because the situation is that both of them, both were without a job. So the situation was pretty difficult for both people to sustain economically the care situation. So, which are the strategies that these populations set forward in order to solve the situation of care? Among the strategies, we find the search of different assistance programs, which help with some everyday life problems. Among those in this population, we had the course for caregiving families that would give them information, and they would facilitate the awareness state in order to set limits to this emotional situation. And from there on, they found solutions for a better organization of care. So, in this case, in these two research pieces of research, there was a course linked to the state of the Buenos Aires city, and the other one was a course linked to a mutual association. Both cases are the kind of help, to help those that give care. That is to say, for the family members that are responsible of highly dependent sick people. So the circle is when I'm responsible at 100% of a time of the other person, which is actually the topic. The relationship of total or absolute dependence with the care. In many cases, we produce also overprotection situations. That is to say, I cannot leave him. So even we have then the case of one of the women that we interviewed, that her mother, the person that was receiving care, was not that bad. Nevertheless, she was dependent in such a way that they wanted her mother not to suffer from anything, that it was like her mother was suffering from a very severe Alzheimer. So that is to say that she wouldn't leave her mother alone at any moment. And overprotection is a very difficult situation that sometimes is given by the families with the elderly citizens due to the fear they have. They want nothing to happen to them. And in many times, they create dependency situations when there should not be any dependent situations. So there are many complaints about this, from the people in the fourth age that say that their family overprotects them, and they're not even allowed to continue doing the things they can do on their own. So, the anxiety situation, overprotection, and the situation of anxiety because I have no life, no time, I can do it anymore, I'm not acknowledged, I have money problems. What makes the courses, that it furnishes them the ability to take distance. So these courses that are sometimes have different contributions, not about only how I can do in order to give support to the person and change her clothes without hurting myself, but also how can I do in order to allow my people around me to help me so I can go out for a while and walk a little bit or run some errands. So this is what in some way these people start seeing. They start to see that there are some resources that can help us to continue with caring for the person. And this allows us, they say, that it allows them to set some distance in this difficult situation, and with this situation of relief and a better health also. As a summary, the families that care for their elderly people and that they are sick, they undergo stress situation and they remain taking care for these people due to some values, moral and ethical. They are kept there from a very strong mandate in the caregiver. And it's about an implicit agreement, which is an intergenerational agreement. We observe that the overprotection of the elderly person makes dependency greater. And this kind of situations, caregiver and cared person, they come with bad relationships. Caregiving families, they talk about high costs, lack of time, lack of future, money, loss of health. The case study that we presented is an example of the new situations that come due as a consequence of the population getting older. And it is necessary to think of creative policies that would support elderly people that need care, as well as for the families and the elderly citizens that care for other senior citizens. So basically, I think of the need of being creative when talking about the contributions, because this sometimes is a thought that it's the caregiving families, they are the ones that have to be responsible for the senior citizens. And families have become they're not families with many descendants. But now there are families that have like 5 generations where the Lord of Care is pretty important. So we have to be creative in all the support and everything that is, at a level of information and at a level of programs that may relieve families, and thus they would be able to comply with their function of giving care. So I will stop over here and I will try to find yourselves later on. Well, Julieta and Ricardo, I believe that what I tried to give a closure to Ricardo's talk, you didn't hear, but the three talks are extremely valuable for social security and for health policies, thinking of senior citizens. The piece of information that you gave, Ricardo, about those previous 20 years of the development of the cognitive deterioration, dementia, indeed is brutal for the planning of the health policies. And can you hear me? And this link with the cardiovascular pathologies and diabetes. So if we take a look at this, indeed, we are embracing with these actions that are shared for the great pathologies of the human being, and that we're searching for this satisfying elderly age to, become old and be well. And what Julieta says about this so well detailed and so personalized and individualized, what it means to families and people, the topic of giving care. We have some questions. One of those, and I suggest if you wish to give a very quick answer. It's not a question specified for each one of us, but a very synthetic answer on our part. So the first question is, how can we block the impregnation of getting older when elderly age is like seen like a disaster or a social cultural disaster? Ricardo, what is your answer to this? I can't hear you. Maybe you should unmute your mic. Sorry. Well, I believe that there is a cultural issue that has to be changed. You know, sometimes you have a model, like I'm a biologist. You have a model of life when the human being would live like 50 or 55 years. And that model has not changed. And actually, a third part of our life is as a senior citizen. So we have to consider that it's a third part, which is pretty important in what has to do with our life. And we have to hierarchize what is positive, the changes. I think that's the point. We have to stop thinking of models where people would die at 50 or 55 years of age, and those that would get to 90 years was the exception. Most of people nowadays reach that age. So we have to generate a society where we would include that third part of a life. But that is something that we have to generate a complete change, because that's where the problem lays. Take persons or people to lack of activity. We have to generate changes over this way of thinking. Julieta? Well, yeah, of course, this elderly age is pretty present, and with the COVID situation emerged in all the media permanently in relation to presenting people as something homogeneous, when diversity In the elderly age, uh, there are many ways of reaching elderly age in many situations, and it's just like Ricardo said. We continue thinking when think of family terms. I would think of my grandfather when he died at 50 years of age, and nowadays we have a lot of uh, grandfathers and great grandfathers, but many of them, only a minimum part of the elderly people, they die without, even though they are fragile, they still can do many things on their everyday life. So we have to work a lot on demythifying on the negative image of the elderly age. When thinking of a little bit of the person that makes or asks the questions is how to block the idea of the elderly age, I would say that not to block actually, but work on to visualize this idea. So, for example, by asking yourself, what happens to me with this? Of getting old, what happens with the elderly people that I see and that are around me, what happens to me with what I imagine for the future. I think we have to work a lot on the social aspects by visualizing the way we deal with the elderly people topics in the mass media. We have to talk about this from the very early ages in education, and the contact and acknowledge of what an elderly person may be, and mainly to start thinking of their desires, the desires of senior citizens. So this is a concrete idea where we can work with. So I hope the answer would have had an answer. Another question is about, and we're going to give this question to Ricardo, is dementia genetical? Why is there more dementia in Europe? Is it that in Europe they detect it, in America they don't? Well, the first point that we have to say is that dementia is a syndrome. It's not an illness. There are several illnesses that produce dementia. Dementia, like fever, it's a syndrome that comes after several causes. There are causes that are genetical. There are some other ones that belong to the environment, and the two main causes of dementia are Alzheimer and vascular dementia, which are around 90% of the diagnosis. When you think of Alzheimer, the genetic ways of Alzheimer are the 3%. 97% are the sporadic, what we know everyone, as we all know. And there might be certain trend, but there are many causes. It's not only the genetics that is there in play. A third question: what actions, and here we all can say something, what kind of educational interventions have been developed with the informal caregivers, considering gender, educational background, and diversity of ages? Julieta, please. Well, at least in Argentina, but also in the region, there are several levels of formation or education for the generation for gerontological helpers. There's a lot of acts, it's different uh, depending on the CISS regions. There are some regions that have greater proposals, and others that they do not have that many proposals. What is interesting about this region topic is that all countries say that it is necessary to have more training in the generation of human resources for the attention of senior citizens. What I was telling about this particularly, some experience, specific experiences, taking care of those that give care, having those family members that ask for help. What I think is that besides the teaching courses, there should also be a programming or planning which would be very precise and very exact around all the process of care needs. It's like having experiences, but we do not have very well prepared the whole process of, following up the care for the period of those people when they need care. So I believe that we're still needing a greater support in the social and um, policies and programs for the families that give care and those that need care. Ricardo? Yeah, I agree with Julieta. I believe it's paramount to generate more programs related to the support to the family caregiver, if it is the family caregiver, as well as the assistant, if it is a third party. The great problem, I come from the clinic, I do clinic. And the great problem when you have the diagnosis and it evolves, it's not the management of the patient, but the management of the family member, because it is pretty common that the family member has trouble if we do not manage the situation. The stress that he undergoes is enormous. Remember, we're talking about sicknesses that take 10 or 15 years of evolution with a great dependency. So if we do not do as Julieta says, and if we don't give them follow up, and if we don't teach them that they need to have their own time and place, the family member ends up having trouble. I have many patients that have became sick and even dead, and my patient is still there. And this has to do with a mismanagement of the environment and the situation. And for this we need programs, and we need to understand the whole situation. As Stella was telling us, it's not the illness, we understand it's the patient, but we also need to understand that it's the patient and the surroundings that we have to manage. And we have to have training courses and education for that too. Well, for that question, I believe, and I'm going to have the concept that you have mentioned, that we have to generate health policies that would include these matters in an integral way. They are not isolated actions. It's not enough, the social, civil society organizations. I'm very respectful about that. And Carlos belongs to family organizations, and that helps. But all that requires money, budget, and also to become a state policy. I think that's the great matter. Well, there we have a comment from a person. See, I'm a social worker from Uruguay. I work in social security in Uruguay. Ever since 2015, we have the national system of care that has a personal assistant and caregivers that are trained apart from the family members, and that really relieved the economical and emotional costs of the family, and mainly with the women that historically have played the role of caregivers. And you know what, this is a great thing. The national care system now is suffering with some budget cut offs. So here we have the continuity of a policy. That's a big problem when it's not within the society that this is a right of people. I believe that we have one more question for Dr. Allegri. would you be able to present? They want an extension of your presentation. Would you please show your slide of the prevalence of dementia and say why Latin America has the greatest values? We shall prepare a new talk.
I would need to make a new presentation. The model is a model, and that's where all prevention work comes in. I mean, the counterweight to that, Nordic countries, Switzerland, Finland, they actually foresaw a prevalence of dementia that's going down right now. And they started asking how come they had less than what they expected, and they had less of it because they acted through prevention policies. The problem in Latin America, and I'm not talking about Latin America in general, but the problem in my country is that we don't have prevention policies, and as long as we don't have prevention policies, in some systems, there will be prevention, and there won't be prevention in many others. And not having prevention will bring about more disease. And I'm not only talking about dementia, I'm talking about more disease in everything. But it will produce more cognitive deterioration. So I think that's a model we should be striving for, like Ella mentioned. I think it's a priority that this disease is being handled in a better fashion by the government and through prevention. But not only prevention in old age, but prevention throughout person's lifetime. So I think that would be the reply. So from your experience, what is the best way to deal with death? Julieta, I don't know if you have experienced this subject or... I mean, of course, you have your own personal opinion. Well, yeah, ultimately, that it will be my personal opinion, and I directed a thesis work about that subject. But I mean, what do you mean by how do you handle death? I think that the question is geared more towards that we should work more with palliative care. Probably that's where the question is going towards. And, well, taking into consideration last wishes of people in deathbed, for them to be able to decide or have a say on how to make this last transition, if you will. So yeah, I consider that's what you should be doing. For the person to be really listened to regarding his or her last wishes, and about what type of care that person wished to have in this last final stage. What about you, Ricardo? I lost the question because I have an erratic connection. Yeah, again, from your experience, what's the best way of dealing with death? I mean, in your daily practice, I don't know if you're going to kill me, but I missed the question again. What is the best way to what? To deal with death, to handle death. What is the best way to deal with death? I think that's a philosophical question, really. And it's really existentialists. And based on what each one believes individually. All that really depends on everybody's philosophical base on what life is. Religion, being not religious, there are many factors that have to do with how one deals with death. However, I believe that the patient's decisions are paramount. That's something absolute. I mean, I think that the great change in modern medicine is going from paternalism, decisions of professionals, to decisions of the patient. I think that that's what should be done. Just an interesting experience. There's been some workshops on a proposal called Death Cafe, where elderly people get together. It's usually a psychologist accompanying them, and well, they talk about the subject. I think that's a strategy. But yes, I completely concur with Ricardo. And what changes would you propose at the institutional level to change paradigms in old age? Julieta? I'm trying to get the question. Can you repeat? Yeah, what changes would you propose at an institutional level to change the paradigm surrounding old age? So I think that the question is too broad. I mean, what do you understand by institutional? If this has to do with those organizations pertaining to attention, what type of attention? So, firstly, what I think is that there is not a paradigm surrounding old age. I mean, there are different ways to live old age. Old age is a construct. It's a construct that's generated throughout the course of life. And well, ultimately, this might be a social paradigm that has split society and that has ultimately generated homogenization of what old age is. So, thinking of old age as a construct of something that happens throughout life allow one to have different old ages, different stances, and maybe what policies there should be regarding different old ages. Again, depending on the different constructs of old age. And on the one hand, you have retirees, you have dependents, vulnerable people. I mean, again, you should really think about this differentiating constructs that make up old age as we understand it today. So, from that standpoint, I would say that institutions should think from a legal standpoint and how old age is something diverse and how this diversity need different ways, different policies, and different differentiated approaches. I think that's the way to looking at it. And in that way, we would be eliminating the anti-old age constructs. Very quickly, for instance, we understand old age as, once a person turns 60. But there are many myths and prejudices regarding workers of certain age in relation to all those things older people cannot do. They cannot get trained. They get sick more often. They cannot do this, to do that. There are many ideas surrounding older workers based on myths and prejudices that make this group of workers not to be able to go into the work market, for instance, just because of prejudices people have in human resources regarding age of workers. So these are prejudices on people or senior citizens. So a change in paradigm should work. Based on that these are myths and prejudices, and will modify many social policies and even health policies, because many times part of healthcare is linked to certain prejudices that say, well, you are of this age, ma'am. Your knee hurts because you're 60 or you're 70 or you're 80. Right? So I think that should be the work regarding modifying the way we look at old age. I hope I answered. Ricardo, do we have a medication that allows to diminish Alzheimer's? I mean, I cannot really get the question. I'm sorry, I could not hear it. Do we currently have a medication that allows to decrease Alzheimer's? Currently available medication are symptomatic. This makes the patient have a better quality of life, but they don't act directly on the disease, per se. Nowadays, there's work on antipathogenic medication, acting on myeloid and tau protein, which are components that have to do with the disease. But the medication are not in a clinical sphere. As a matter of fact, past Friday, there was a big discussion in FDA because an anti-amyloid was introduced, and there was this whole discussion behind the effectiveness or lack thereof of one of these pieces of research. But, I mean, we need to keep waiting for that stage. So right now, the medications we have are symptomatic. I don't think we can draw many conclusions to this table, but going over this subject once again, and I think one of the objectives that we set for ourselves at CIS and GADAM regarding senior citizens is that all these things actually make it to decision makers. So all the products from our international organizations are not binding, they're recommendations. So I think that they in the different work tables, there are very punctual guidelines on state policies to benefit and uphold the values of Social Security. So that's it on my behalf. It's been great sharing this this morning with you in the framework of this conference. I hope we can keep growing and talking about these subjects. So without further ado, I will pass the floor to Marcela. Thank you very much for your participation and for your contributions. Doctor, thank you. Thank you to our panel members. There's a lot of food of thought and a lot of work to be done. And like the American Commission on Senior Citizens have said, these are things that we're working the inside of the Inter-American Conference Social Security for all these guidelines to actually make decision makers, people who can make out of this a working program and provide some sort of compliance. Thank you very much, President of CADAM, Dr. Estela Arcalev. We couldn't introduce her because of connection problems. She's a specialist in geriatrics and gerontology, director of Mutual Association of Agents of Senior Citizens Organizations, AMAOTE, teacher in the Danús International University, director of confirmation course of Gerontologic Assistance, sponsored by the city of Buenos Aires. So a doctor and the other researchers today with us have a lot to say. We always run out of time. But again, thank you very much for accepting our invitation. Thank you very much for all contributions and for replying the questions presented to you. Again, thank you very much and have a good morning. Thank you on behalf of the Inter-American Conference on Social Security and the American Commission on Senior Citizens. Have a good afternoon. And in 5 minutes' time, we will start with our second working table. on today's work on the online conference on mental health and social security. Thank you. Hello and good afternoon. Welcome back again. We had a 2-minute pause in this online conference on mental health and social security. In the morning, we had a presentation by Karam, everything pertaining to mental health of senior citizens, with participation of brilliant experts in subject matter. Now we have another very interesting working table in charge of the Inter-American Commission of Labor Risks. And we'll have an expert, and he'll talk to us about mental health and work risks. To this end, we have Dr. Graciela Montalvo. She's president of the American Commission of Prevention and Risks of Labor from CISS, and she'll be the moderator, and researcher Javier Garcia Ribes. He's also a researcher from CISS. Let me introduce Dr. Gil Montalvo. Like I mentioned, she's president of CAP. She's also director of assurance risk in labor from the Dominican Republic. President Graciela Gil Montalvo is also the director of the Latin American Association on Security and Health at Work in the workplace for the Dominican Republic. Welcome, President, and welcome, Doctor. The floor is yours to kickstart this second working table on the online conference on mental health and social security. We'll be talking about this subject, and at the end we'll have a Q&A session presented to you by the moderator. Thank you very much for being here, and have a very productive working table. Thank you very much, Marcela. Good afternoon, ladies and gentlemen. The American Commission Prevention of Work Risks. I'd like to thank you for the opportunity to partake in this online conference on mental health and social security, because, as a matter of fact, this subject is transversal in terms of management, risk management, that is in companies. Take into consideration the psychosocial risks present in the work environment that have to do with workers' health condition, productiveness of the company, and social well-being. WHO defines mental health as the complete state of well-being in which the person carries out full potential and is capable of facing normal stress of life, being able to work productively, and contributing to their community because of that. So in labor environment, we find negative conditions regarding organization, social environment, and even the content of work, its execution. And all this might bring about not only psychological damages, but psychological damages can be summarized, thus producing physical damages, generating negative consequences and behaviors and attitude for the mental well-being of the worker, again, as a consequence of a work-related stress, which many times the IoT defines this as an ailment in a context. And this is owing to exhaustion or even a depression. So that's why it is important to observe different health policies in the work environment. We need to make sure that there is no overburden of work. If there is uncertainty, lack of inclusion, little participation, and efficient communication amongst other co-workers in the work environment, that might represent the risk for mental health in workers. Back in 2010, the ILO went over the list of professional-related diseases, and they incorporated mental illnesses and other diseases, or rather problems in behavior when it's demonstrated direct link to the work. However, most of the countries do not recognize the work origin of mental health related to present factors of risk in the work environment, and even some prevention services among employers and other authority positions in the same system consider and associate the psychosocial factors to an extra work situation or the intrinsic capability of an individual to be able to better handle the work. So we understand that not regarding this as a labor-related disease or not incorporating it into a list of professional-related diseases is a practice that might be promoting some sort of a healing strategy rather than a preventive strategy, which is what should happen. Because in the framework of security and health in workplace and risk management, we need to tackle the origin through responsible actions to elimination of risk factors. That might unchain or make the problem worse. And we cannot stop. I mean, we cannot talk about the impact of a pandemic due to COVID-19 right now. In the psychosocial risk factors that are worsened because of that, because of confinement, work modification, work insecurity, unemployment. And well, all this comes from being overburdened with work, disconnection, lack of connection, rather, associated mental illnesses related to very restrictive controls by the employer, and all these new modalities of work. Now, I would like to make reference to Delphi piece of research published by the European Agency on Security at Work, and they commended a group of experts to identify emerging work risks. And, well, they quote precarious hirings in the context of an unstable work market. They also quote the new ways of hiring, a feeling of insecurity, long working hours, amongst others.
So, the American Commission for the Prevention of Work Risks promotes the investment and the promotion of mental health and tells us to the countries to include in the management of prevention in the companies psychosocial risks and the participation at all levels of hierarchy of the companies, especially on the psychosocial risks such as stress, harassment, discrimination, work discrimination that would need more time to talk about. And why all this? Because it's going to be cheaper to talk about prevention than spending money in the illness. It means impact in the productivity, it means competitiveness, and, work absences, and many other things. For the worker, they mean expenses in health, stigmatization, and difficulty to integrate in the work market. And as said previously, it promotes the it may cause the consumption of alcohol and psychotropics. They cause disabilities and anticipated retirement, which have an impact on the person, the company, and the society. But at the same time, it affects the sustainability of our social protection system. And with this scope, we wanted to introduce the results of a pilot study of one of the groups where we've seen this the most, the impact of the psychosocial factors related to the organization and work conditions that are being worsened by the pandemic. It's about the study of the mental health for the health staff for after COVID-19. I'm very pleased to present the great professional Dr. Javier Garcia Rivas, doctor in public health by the University of California in the United States, has a master in organizational psychology by the University of the State of Morelos in Mexico. She has been a teacher. He has been a teacher at the University of San Martin de Porres, University of California, Autonomous University of the State of Morelos, Morelos and Mexico, and in the CETES University of Mexicali in Mexico. He has more than 10 years of experience as a researcher, and he has numerous articles in magazines and chapters of books. He has been a speaker in international events, and he's a consultant of psychosocial risks at work. And nowadays, and I'm going to say this positively, he is our specialist at the companies, the Association of Work Risk for the CISS. Dr. Garcia, the floor is yours, and we'll be waiting for any question. Thank you very much for your warm introduction and for the presentation of such an important topic. Sorry. Well, can you see my screen? Okay. Well, as it was well said by Dr. Hill, we're going to present the results of a pilot study that we have had to assess the risk, the psychosocial risk factors and mental health in general for health personnel during the pandemic. And now I am focused specifically in health personnel in Mexico. It's the population we've been having access through the collaboration with colleagues from the University of Morelos and other universities in Mexico. This is the presentation plan. I'm going to give a little introduction about this work. We're going to discuss a little bit about how we determine the mental health topics or mental well-being. Now we're focused on working with burnout, stress, and depression, specifically for health personnel, and this is why we're using this term and not health professionals. We're going to present the methodology, the results, and some other products that have been a consequence of this work, and also the conclusions that we have reached. As it was well said by Dr. Hill, our task in occupational health has this approach or this spirit of prevention. Mainly for many reasons, but mainly because all of us are awake most of the time, most of the day, at the work place or in activities related to work. That is to say, commuting, reading emails, answering messages now. And this line, up to a certain point, clear about the working schedule and the personal activity schedule, which has vanished during this pandemic. But in the case of health personnel, it has not necessarily vanished. Many of them do not have the possibility or have a presentation from home, but other activities we've seen, an increase in the number of patients, in the number of hours they spent at the work place, and the psychosocial load demands at the workplace. So this is why we're focusing on this population from, the SARS-CoV-2 issue. So this effort for obtaining data for this pilot is part of a greater image that we entitled the Health System in the Americas Before the Pandemic, a perspective to universal coverage and access. In this case, in the point where we have to work or contribute, we emphasize the importance of the health personnel to warranty the coverage. So I'll be describing the details of this work. Well, then, Generally speaking, the WHO tells us that there are around 800,000 suicides per year, and most of them are attributed in some way to problems of anxiety and depression, which, according to data from the WHO, there are around 300 million people affected by this. We would then assume, I would dare to assume, that even that data or those data are subestimated due to the lot of stigmatization that we have on mental health in the world, and especially in our countries. Logically, the people that suffer these, once they identify certain traits of deterioration in their mental health, it's up to 85% of people in countries with a low and medium mid income, where most of our countries belong. They do not get any treatment. So it's a neglected topic. We calculate also on the part of the WHO that by 2013, depression will be the main reason for disease. Up to now, or last year's data calculate that 7.5 years, healthy years, are lost due to depression or symptoms related to depression. In the case of anxiety, we calculate that it's about 3.5, 3.4 years. So these pieces of information from the pandemic on make us think, you know, given some research and according to the specialists, they suggest that it's going to be worse and they're going to be more serious in the future, relatively in a short period of time, but essentially in the long run. Stress and burnout is one are two more topics that we deal with in this study, where the American Association of Psychology, the APA, has calculated in some research that 75% of adults have experimented moderate and high levels of stress. That is to say, that stress, in this case, they talk about general stress, may be actually due to financial issues that many adults report as the cause of stress, which is, but we also have included this work issues, and there are some studies about burnout. This is a little bit of a complex topic. We're not going to give further detail because that's not our objective now. But in some systemic and meta-analysis studies, up to 80% report having had burnout or any of their symptoms. Obviously, there's a discussion that some of these concepts between burnout and depression, it seems like I insist there's discussion that they're the same. Nevertheless, what we've seen here is that they're not exactly the same, but there is like comorbidity. That is to say, they present at the same time in the people without necessarily being the same psychological disorder. So this is a little image spread out by the social media, and I think it is important to mention it, not in the scientific sense, because there are not any background data, but I think it is important and interesting because it gives us a field for a discussion. The way the burden in health is being generated in the next years or the years to come from the pandemic on. We have had a first wave, which is the immediate attention due to the virus, and obviously there's a recovery period. Nevertheless, there's a second wave, they say, where there is an impact on health. because we have been overwhelmed. Health systems, they neglect some other emergencies, and finally there will be a longer term impact in the interruption of care and follow up of chronic diseases, because people stop going to pick their medications, and they miss consultations, and they miss attention, etc. And obviously, since they are vulnerable population. And finally, what we're interested in is specifically now we're talking about a fourth wave of psychic trauma, mental disease, economic failure, or burnout, not only by the people who suffered from the pandemic, but also health professionals that had to give attention to this pandemic. So, from this suspicious, the WHO has decided to intervene in this mental health services massively. And before this crisis that we suppose it's going to reach us at some time, we also know that health systems were not ready to face the number of infected people by SARS-CoV-2, but at least in the low and mid size income. So it's pretty important that in our countries we pay attention to this fourth wave, as mentioned by the previous slide, of mental health illnesses that we will be suffering from. So what we now have some studies in Asia and Europe. We have some efforts from other colleagues working with the topic in Brazil. Still, in this case, we obviously want to deal with what we have found about these topics in the health personnel, because during the pandemic time, their working conditions have been more intense. But besides that, they have not generated programs, or at least not massively, as we will said in this uh, slide, to prevent and address the mental disorders caused by the excessive working conditions. Why did we decide to talk about health workers and not professionals? Well, basically because we did not want to exclude the rest of workers, in this case, thinking of other people that actually are exposed and also in this first line of defense. Obviously, they must acknowledge the effort and work of doctors, nurses, internists, etc. But we cannot exclude the importance of the work of, you know, reception personnel, uh, guards, and all those that are also in contact with the workers. So when we decided to include these workers, in some way we understood that not everyone would have access to, would be able to answer our questionnaire. Actually, our seats, we call them, in order to spread the questionnaire. But anyways, we didn't want to exclude them from the very beginning. We know it's not a representative number, and that's what we're going to be talking about later on, and also about their characteristics. So this pilot is about a more experimental and transitional and descriptive model. We had a aleatory recruitment, because we did not have a framework or sampling frame in order to have a way to select our population. So what we did it was a sampling throughout a snowball strategy where we sent our questionnaire to what we call the seeds, and then they helped us spreading or to spread the questionnaire, and on their turn, they will refer this questionnaire to other colleagues. So we had a sample of 296 health workers, non-professionals, because we included some other people, but we only got a sample in Mexico, even though we had some answers, a very few answers from Colombia, like three, and the United States and California, and those other three. So we decided to focus now Mexico, specifically in the center of a country. And what we did is that amongst the many other questions, we're going to be focusing on matters regarding health and other findings that we I will present later on about a technique of quantitative and qualitative analysis to identify the psychosocial risk factors, but also to identify the possible resources the health personnel has to face these work risks. Among the instruments that we used, we tried to use instruments which are very brief, assuming that the health personnel does not have time to answer 30 or 40-minute instruments. So this instrument we prepared takes around 15 minutes to be solved. Maximum, and we used a scale of depression of 2 items, anxiety scale of 2 items, and an item for stress or stress symptoms, and one more for burnout. Those with validity work in Spanish. And what did we find? That around 17% of our population presents more than half of the days or every day depression symptoms. More than 27% report to have symptoms of anxiety more than half of days or all the days, according to the response categories, and more than 44% report having suffered from stress almost always or always. And in terms of burnout, they say that more than 46% that definitely they have burnout symptoms. That would be the exploratory part about health and mental well-being in health personnel. Nevertheless, we've also worked with this same sample in the other article that we have already sent to be published with this kind of work, as I was telling you, with the Autonomous University of the state of Morelos, where we had this exploratory work, which was mixed, where we openly ask the participants which are the aspects that provoke the most stress in the pandemic, and they tell us freely what causes stress to them. But we also ask them about the positive aspects, which are the resources or support that you take to cope with stress during pandemic. So I'll go back and then we'll see this slide. In this case, you can see that we use less population than in the previous report, because in this case, when they're cleaning up, when we were doing clean up, we eliminated some duplicated cases, but we also used those participants that answered this part of the questions. So, when doing the qualitative analysis of the answers from the participants, we found five big topics in the part of stress, and we found that something that generates lots of stress to health personnel generally is the fear, the general fear, but let's say in specific terms, when we analyze them, most of them talk about a fear to be infected or infect their family members and the general discomfort. And they also talk about obstacles and the lack of resources. That is to say, not having the proper material to work, the load of work responsibilities, that is to say, the number of patients they work with, or the hours they spend at work, it's too much. And number four, I was talking about the fear of getting infected for them or their family members. And number five, difficulties on our everyday life. That is to say, going out, going sightseeing, and do some exercise. But what are the support items that they have to cope with stress due to the pandemic? They talk about individual strategies that are anti-stress. That is to say, personal tools of self relaxation, breathing, reflection, the religious and family support, the compliance with sanitary measures, that they feel sort of safe by knowing the sanitary measures and follow those. The organizational support, personal support, and from friends, and resources and rewards that they receive either by the institution or external people, like donations, for example. Sorry, a little second. Well, then, and lastly, we included one more part when many people said that they did not have any resource. So this apparently would go in the first part, but we identified it in this second point, in the second question, where they do not have any kind of resource to cope with the stress generated by the pandemic. So once we have identified in the qualitative analysis the responses from the participants, then we continue having a quantitative analysis in order to assess which the health indicators it is linked to. We had, like, for example, in the negative psychosocial factors, the lack of self protection is positively associated with anxiety. And we see that associations, even though they're small, and we could then think that it is due to the lack of statistic power in the sample because it's a small one, we see that they're in the right direction, except for the social distancing or isolation. This social isolation is seen as something negative, but it's associated. That is, the greater social isolation, less anxiety and depression. And we suspect that this is one of the weaknesses of this job or this work. We do not have direct access with the personnel in order to explore qualitatively these results, but we could then assume that when people lock themselves out and they are isolated socially, they see this positively and generates less anxiety or depression because they are not exposed to the virus. This is an interpretation that we had about this issue. But what we also see is that personal resources are equally associated negatively. That is to say, the more personal resources I have, less my depression systems, burnout and depression are, except for this part of none that I was telling you about, which is positively associated with burnout and stress. Even though you see that there are little associations, they are statistically important. So that would be the second part of the results that we've been finding. We have more data. We're planning to continue working and some of us analyzing other risk factors that are interesting, such as, for example, the working hours. That is to say, we have had an increase in the working schedule for the health personnel, but we've also increased the workload with the number of patients they work with or the number of people they receive. So, what are our conclusions? That health workers during the pandemic in Mexico have negative levels of mental health, which are higher levels than expected. There is a relationship between the conditions of work and the working demands during the pandemic and the indicators of mental health in health workers. It is not possible to generalize our results because the sample is not representative. So it's necessary to increase this sample in order to make another kind of analysis, that is to say, to stratify by occupational work in order to see who is being more impacted by this kind of problems or by age groups. And then it is important to compare it with other countries, member countries. So this is where I invite you and our colleagues and administrators of health institutions in order to help with those in this job and help us collecting this data that will enable us to have this kind of analysis.
And in this case, to be able to get a sample that will allow us to carry out this stratified analysis. Very well. I think I stopped sharing my screen. I don't know why. So please bear with me just a second. Well, at any rate, that will be the end of my participation. And well, aside from the invitation to cooperate with us, here I'll leave my POC. Doctor, thank you very much. For the time being, we have no questions for you. I mean, either you were very clear or people are still thinking what you said, because the truth of the matter is that everything pertaining to healthcare workers and even first-line responders during the pandemic, I think that they're all subjected to a huge degree of danger. Do you have any idea number of suicide among these type of workers, doctor? No, I don't have that piece of information right now. Okay. Doctor, and what about continuity? Continuity regarding this piece of research you're working on? Are you looking to broaden the sample size of population? Are you still going to be working with healthcare providers? Yes. Yes, that's what we're all trying to do. And like I mentioned at the end, to be able to compare at some point in time, because this information is only what we've gotten from Mexico. And even within the country, we could not possibly speak or make any generalizations so far out of this sample alone, but we are interested in getting a better sample to be able to contrast and compare with other countries. It calls my attention, doctor, that the lack of PPE or personal protective equipment might have to do with the rationalization of this type of personal protection equipment. Anything else aside from training, orientation that people must get? No, like I mentioned during my presentation, we haven't arrived really at this part where we can actually create focus groups to try and better identify which are the best way to tackle this from the workers' perspectives, because well, there's obviously strategies coming to top down from institutions or directives, but it's always interesting listening from workers which might be the best answers to this, because they're there in the field taking care of people. We just got a question for you, doctor, and it reads: Are there any proposals or plans to decrease these indexes of stress or anxiety to be implemented in healthcare workers? Yeah, that's a great question, Doctor. It is my understanding that Mexican Social Security has implemented some mental health conferences, and they've been placing emphasis on mental health professionals. They have psychologists in some institutions to be able to offer some workshops to the personnel working on the emergency. I have a colleague of mine here in Morelos working precisely on that. However, again, we don't know if that's something that's generalized. However, something that strikes me as important, worth highlighting here, is that even if these are very important measures and obviously relevant to try to decrease, like you just said, symptoms of stress, depression, and so on, it's still very important, placing emphasis, like I mentioned at the start of my presentation, everything they have to do with preventive measures. Not wait for symptomatology, but rather implementing preventive measures. And well, for you make sure that the workers have necessary piece of equipment, better working schedule, and so on. Doctors, do you have any comments on the Federal Labor Act as it pertains to healthcare workers? I don't understand specifically what the question is talking about. I don't know if you're talking about this not being included into the act, maybe diseases. I mean, owing to COVID as some sort of professional or labor-related disease. Sorry. So, doctor, is there a strategy to incorporate these services for mental health for healthcare workers? I mean, integrating that into the prevention services? Oh, okay. No, I don't. I don't know if they're including healthcare workers in general, or these are exclusive to for health professionals. Because I think this program should include them, of course. Everybody exposed, really, and that the working conditions have been affected. Yes, an obvious consequence of the pandemic. Doctor, just to compliment about the Federal Labor Act, saying that health staff under stress are made work with COVID patients in Mexico. Again, I don't know if the Labor Act specifically mandates that they have to work with COVID patients, but I understand that they don't have a possibility of any type of absenteeism from their work while the medical emergency lasts. I understand that there are some cases, and again, I'm talking about anecdotal cases when some people are sent back home because they are in this vulnerable group because of the chronic or their age, but I don't know if that's being implemented throughout. Doctor, I don't think that we have any further questions. I don't know if you have any last messages, thoughts on today's topic. Yeah, I mean, very, very short. And just probably going over the same message. Healthcare workers are extremely important. We need to take care of those people taking care of us. Not only because of the emergency as such, but because they'll keep taking care of us once the pandemic is gone. So again, it's very important for us to detect which are these work conditions that we can improve upon in which we can make modifications that would help prevent health care problems. Health problems to come in this population. And again, there's this invitation for you to collaborate with us so that we can have a larger sample and more precise, more precise data of to the research we've been doing so far. Well, I think we do require this support from countries to be able to collaborate with the requirements and consultancies that member states require from CISS. And of course, we're working on this because this is the most immediate thing in the pandemic. We shouldn't lose sight that in general, it's necessary to include healthcare workers in everything that has to do with labor risk management company. All the psychosocial risk factors because of the impact. Remember, not only in the health of worker, but the organization, which is your responsibility, and obviously, the sustainability. We will have safe workers. We should have health and healthy workers. If we include everything pertaining to mental health for our workers. So those are my two cents. Calling upon the investment in mental health to all employers. Marcela, the floor is yours. Yeah, I think it's very important for the Inter-American Conference, Social Security, everything that has to do with mental health, like you both just mentioned, is something we'll keep working on next year. Because it is plain to see that we haven't finished doing so. It's something that maybe most of the countries or the region, we haven't really given a lot of weight to because of the demand. So we should take into consideration not only physical health but also mental. So health of all the workers, mental health is something that's been on the table, especially because of the pandemic. Because everybody's undergoing a crisis to be able to handle everything that's going on, plus still work their day-to-day job. And when hospital workers, medical workers, mental health problems become more acute for them and in their social and family environment and everybody else involved. Unfortunately, some people haven't had a good reaction to this, and we need to carry out emerging measures. So I'm glad that we were talking about this at the president of the commission. I know that she's very committed to this subject as well, and that we'll, of course, keep working next year for mental health for workers to become a priority for countries in the region. So on behalf of CISS, would like to thank you very much for your contribution. Thank you very much, Dr. Graciela, the president, for all your work. And we'll be reporting through our webpage the conclusions of this conference. And we have six American commissions to follow. We had senior citizens in morning, and we also have legal, social security administration systems. So these are commissions, all working thematically in favor of the members of the institution of Social Security in the Americas. So we'll keep working on this in the webpage. You can find a lot of resources, a lot of information about it. You can find documents, everything that's been generated so far, and will keep being generated so that you'll be better informed. So again, thank you very much, Dr. Graciela, Dr. Javier Garcia Rivas. And if you don't have anything to add, President, I would close or formally close today's session on the online conference on mental health and social security. Again, I'd just like to call upon carry out protocols against workplace harassment, violence, workplace discriminatory harassment, and sexual harassment. Because that's a really extensive subject that should pertain to another conference. Thank you very much for your invitation. Yes, it's of course something that worries us, and something that we will certainly tackle because it deserves its own special place. And I mean, aside from research and anything that's been put on the table, we will of course talk about harassment to shed more light on it. So thank you very much. Thank you very much for our audience. So have a good afternoon.